really glad to be here. I'm really honored to be chairing this section along with my colleagues, Professor Mo and Aung from University of Medicine too. As an introduction, adrenal disorders are serious conditions caused by hormonal imbalance within the adrenal glands, with primary aldosteronism and 𝗣𝗵𝗄𝗧𝗏 tumor being particularly significant due to their links to the hypertension and potential life-threatening complications. Especially pulmonary embolism results from the overproduction of the aldosteronism by the adrenal cortex, leading to symptoms like high blood pressure and sometimes low potassium. 𝗣𝗵𝗄𝗧𝗏 tumor, rare tumor of the adrenal medulla, secretes excessive catecholamines and causing symptoms such as headache, palpitations, and can be lethal if missed. Understanding these distinct disorders is crucial for timely diagnosis and appropriate management, which can include surgery and medication. May I introduce the first speaker of this section? He is going to talk from Singapore. Dr. 𝗏𝗏 is the head of the Department of the Endocrinology and Adrenal Hypertension Center at Chiang Ghee General Hospital, Singapore. As a senior consultant endocrinologist, his area of the interest is in adrenal hypertension and primary aldosteronism. He was awarded an overseas fellowship in 2014, spending 1 year at 𝗏𝗏𝗺𝗏𝗵𝗏 University Medical Center, Nijmegen, Netherlands. After completing his PhD in National University of Singapore, he is currently funded by the National Medical Research Council of Singapore as a clinician scientist. He has led several clinical studies, including multi-center trial in Singapore using non-invasive PET-CT to identify unilateral surgically curable primary aldosteronism. He is the current president of the Asian Network of the Adrenal Hypertension, focusing on improving treatment of adrenal hypertension in the region. Dr. 𝗏𝗏 has a strong passion in education and research and has supervised numerous medical students, junior doctors, and clinical fellows for clinical research. Now, may I invite Dr. 𝗏𝗏 to give you a lecture from Singapore, the topic of which is a comprehensive care of the primary hyperaldosteronism multidisciplinary approach. Shall we welcome Dr. 𝗏𝗏, please.
Thank you very much, Prof. Zol and Mo Aung, for introducing me and chairing the session. I just want to check, can you hear me clearly? All right, so let's get started. Treating PA this is something that I got from one of my colleagues after I came back from a conference, and this was a WhatsApp message, and she said, thank you. Just saw a PA patient post-op aldosterone-producing adenoma who was weaned off hypertension and potassium replacement. Very thankful, one of the more satisfying conditions to manage. And indeed, PA is really very satisfying to treat. So primary aldosteronism, or PA for short, occurs when the adrenal glands overproduce aldosterone. This leads to hypertension and low potassium. And we can treat it with medications. We can treat patients with medications for blood pressure and hypo and potassium supplementations. But really, they need targeted treatment with mineralocorticoid receptor antagonists to really combat the effects of aldosterone. Because we know that aldosterone has harmful effects through the mineralocorticoid receptor on the heart, the brain, the kidneys. So patients with PA at higher risk of cardiovascular disease and renal disease. We also know now that some of these tumors produce cortisol. And the best treatment really is going to the source. And in patients with unilateral PA, it is a curable condition. And I think that's really something that all of us as endocrinologists would really like to treat. So this is a summary slide of the current practice. We have a screening test. We use the aldosterone-renin ratio. Depending on your units, whether you're using nanograms per deciliter or picomoles, this will be the cutoffs for an ARR that's elevated. Generally, we prefer that the potassium is replete, 3.5 and above. Patients are not on spironolactone. And the use of ACE, beta blockers, or diuretics can be used and interpreted accordingly. For confirmatory tests in Singapore, we use a seated saline suppression test, post-saline aldosterone more than 6 using LC-MS, mass spectrometry, or 10 or more using immunoassays will be our cutoff. For subtyping, we routinely perform CT imaging with contrast because we want to visualize the adrenal veins. And for AVS, we routinely do it with co-syntropin, ACTH, to improve the cannulation rates. And we use a lateralization ratio of 4 or more. But do note that AVS may reduce your lateralization ratio. Now, I understand that in Myanmar, we do not perform AVS, and that is fine. I'll share some more data on that later. And depending on whether we think it's unilateral, we offer them surgery. If it's bilateral, we treat them with medications, and the doses that I use are listed as below. So let's go to case 1. So this is a patient who has hypokalemia and hypertension. And this is our system that shows, patients' potassium records over the last 20 years, in fact. This patient has chronic hypokalemia. We know that the sodium bicarb is usually on the high normal side, and this comes together with hypokalemia. And what you would notice that in addition to hypokalemia, you would see that the sodium is usually in the high normal range. So this is a patient with 5 years of hypokalemia, 10 years of hypokalemia. This patient had hypokalemia almost 20 years ago, before they were referred. And this is what we see in Singapore. More than half of our patients have hypokalemia for more than a year. The average is 5 years before they're finally referred. So this is something we reported in JCM last year. I think it was published last year. And this is a real problem that patients with hypokalemia are not being referred to us for treatment and further workup. Now I'd like to shift gears a little bit to some very interesting work that I'm doing together with Jens. So this is what we can measure. We can measure sodium and potassium in the extracellular space, or the serum. What we cannot measure is what's inside the body, intracellular cations. So intracellularly, potassium is the predominant cation. And in this experiment, mice were given DOCA, which is aldosterone, with salt. And the mice were sacrificed, in other words, killed every few days to look at what was happening inside the mice. So after a few days of aldosterone, they were losing potassium, they were gaining sodium, and only after a while, the sodium was entering the cell to replace what was lost intracellularly. So really, there's a dysregulation intracellularly, and this was actually shown in the very first patient that Jerome Korn operated on in 1956. So at the point of surgery, this was the patient's biopsy of the muscle, showing that she had a lot higher levels of sodium and a lot lower levels of potassium in the muscle compared to normal humans. Now, we cannot do muscle biopsy routinely in all our patients, but with this non-invasive technique, we have been looking at the sodium levels in the muscle before surgery and after surgery, and these tubes at the bottom reflect the tissue sodium content. And what you can see is that before surgery and after surgery, you can see a drastic reduction in the tissue sodium. So there is a tissue sodium dysregulation in PA. It is not just extracellular space, but intracellular space as well. And we wanted to study whether when we give potassium tablets, whether we can reverse that abnormality. So this was nicely led by 𝗍. 𝗍 is a Vietnamese consultant endocrinologist doing her PhD with me. We believe that tissue sodium is something like a HbA1c. You have high hormone levels or high insulin resistance. You have high dietary sodium or dietary glucose, and then that will give you a readout of HbA1c. So it can be used for diagnosis and monitoring potentially. These are normal Singaporeans, muscle sodium, and this was a patient with PA. Very high tissue sodium at the start. After 6 weeks of potassium supplementation, this is about more than 10 tablets of potassium. You can see that this tissue sodium has dropped down remarkably. And in addition, we see a drop in the systolic blood pressure of more than 20 millimeters mercury, right? So this is actually treating patients. And if you think back at the patients that you treat when you give them potassium, you won't be surprised to remember that a lot of them do say that they feel better. You're all familiar with the renin-angiotensin system. We see a high aldosterone, low renin. Medications can affect your ARR, but really we recommend checking your patients on their medications regardless, because while it can shift the curve to the left or the right, we really want to pick up patients who have a clear-cut diagnosis, right? If we stipulate that they must stop medications, then less people are being screened and we pick up less patients. So really, if you have the luxury of stopping your patients, go ahead. But if you don't, then I would recommend screening, regardless of medications. Aldosterone and cortisol are both produced, but do note that aldosterone circulates at a levels of 1,000 less than cortisol. And because of that, immunoassays may falsely read cortisol as aldosterone. So some key points to note about screening tests and assays. Aldosterone using mass spectrometry is a lot more specific. You would find a lower level by about 20–30%. PRA is generally better for low renin levels. We use this as a positive screening. Saline suppression should be done seated. Post-saline suppression, more than 6 on mass spectrometry has been shown to be an ideal cutoff, if I may. If you do suspect that the patient has PA and you have a negative test, then do repeat. Because some of these patients may have fluctuations in their aldosterone levels. And right now, my motto would be to repeat until positive if your suspicion is high, especially those with hypokalemia. So who should we screen? This is based on the ENDOSOC guidelines in 2016. Because it's highly prevalent, these cohorts of patients, it's more prevalent. You may want to screen them more. But really, the most recent guidelines in 2025, which was just out last month, and even the European Society of Cardiology now recommends screening all patients with hypertension. Now, really, this is also dependent on whether we have the facilities to screen patients. How is it done? You're all familiar. It should be done in the mornings. Again, ideally off spironolactone, and the rest of them, I'm not so particular. And what do we screen? Elevated aldosterone and suppressed renin. So this is the most recent guidelines for the ENDOSOC guidelines. If I may put it in my original graph, then what they now recommend is you can skip confirmatory testing if you have an AR more than 15, aldosterone more than 7.5. Depending if you're using immunoassay, then be more than 20 and more than 10. And this is very relevant. So with Prof 𝗵𝗆 here and fellow collaborators from the whole Southeast Asia region, we did this study and we asked doctors, are you able to perform screening, confirmatory, subtype, and surgery? We were quite surprised that in terms of confirmatory testing, many countries in the ASEAN region do not perform confirmatory testing because they do not have the assays, they do not have the facilities, and some of the assays are actually sent overseas, which leads to a higher turnaround time. So even in Singapore, we were sending it to Mayo until 2023. Now we have our own lab where we can measure ARR on mass spectrometry with a much faster turnaround time. Now, subtyping, you're all aware that CT may not always give you the right result, and adrenal vein sampling is recommended to compare the aldosterone levels. And again, in Southeast Asia, we find that even more countries do not perform AVS, meaning 500 million people in the world in this region alone do not have access to AVS. In this other study that my student led, we had patients recruited from centers around the world, including Mayo, Michigan, Monash from Australia, many leading centers in the world. We asked how long does it take to eventually undergo surgery. Surprisingly, patients around the world take more than 12 months. In countries where AVS is not performed, it's shorter, 6 months versus 15 months. But in terms of biochemical cure, it is a lot worse if AVS is not performed. So we do have a very good AVS service, thanks to Dr. 𝗪𝗪𝗪𝗪, Prasanna and Alvin. And now we actually lead courses. And we're welcome to share if anybody wants to visit Singapore to learn more about AVS. We have also moved towards functional imaging with PET-CT scan. So 11C-methylmidate is very specific for aldosterone. Here you can see a tumor lighting up. And we also now are embarking on a new study using hybrid hormones. In short, we find that a certain biomarker called 18-oxocortisol picks up these patients with a very treatable aldosterone-producing adenoma with KCNJ5 mutations, and there's almost no overlap with other tumors. In short, if you can find a tumor on CT scan and you find the biomarker is high, these patients can go for surgery. So this is what we performed in Singapore at the top, and in UK, the largest study called MATCH below. So patients underwent both PET and AVS. These are patients picked up on PET, meaning that very few patients will actually need AVS if PET will be the first line. When it came to hybrid hormones, half of our patients could be picked up on, half of our patients with unilateral PA could be picked up with hybrid hormones. This is because the mutation rate is higher in Asia compared in Caucasians, which means that, again, a lot of patients could be going straight for surgery with just a hybrid hormone measurement, followed by PET if you want to find more patients, followed by AVS if you want to find even more patients. So just to illustrate, this is a patient who underwent surgery. Post-op, I just wanted to highlight a few things. We should check the aldosterone-renin ratio after that to confirm that the patients are cured. This patient is on a lot less medications with controlled blood pressure. And I just want to highlight that creatinine does go up after surgery, and this is a common phenomenon. Think diabetic nephropathy. We do see your creatinine going up because of reversal of glomerular hyperfiltration when you treat patients with an ACE. And we do see the same thing when we give patients spironolactone or adrenectomy. So that is fine, and that is actually a good outcome. So surgery generally has similar or better effects compared to medications, but medications are still very important. So my patient before spironolactone in 2019 had poorly controlled blood pressure, and just with spironolactone, she could take off many other medications with better blood pressure. We tried to target a high normal potassium and an unsuppressed renin level. Side effects may be dose limiting. With new novel aldosterone synthase inhibitors being tested, I think we may have a new solution. And radiofrequency ablation is another option. In some centers, they do transabdominal. In this Japanese group, they actually managed to do it through an AVS approach. In UK, they are doing through a transgastric approach for RFAs. So if I may just finish off with one patient, right, to illustrate how the whole workup goes. So this is a patient who came from Malaysia to see me. So I didn't do a screening test. I went straight for salt loading tests because the patient was only going to be in Singapore for 1 day for this. So as you can see, the aldosterone levels are more than 10 or even 6 as a cutoff using mass spectrometry with poorly controlled blood pressure on 4 different medications. In fact, this is the AVS. So on CT scan, we do see a right adrenal nodule, and I would like to go through the AVS. Usually I convert my aldosterone to picomoles. For cortisol, this is the cortisol levels in the inferior vena cava. It's 400. We want to see the cortisol levels going up in the adrenal veins. So in the right one, the cortisol gradient is only 0.97, which means that it didn't go into the right adrenal vein. In this case, we will discard the right one and we'll use the right two for interpretation. So in the right two, you can see it goes up to 38 gradient and the left 14. So anything more than 5 is considered a successful AVS cannulation. We also check the renin and the potassium on the day to see if this can affect aldosterone levels. Hypokalemia was persistent, unfortunately, but it didn't affect the final AVS results because you can see that the right 2 aldosterone cortisol ratio is 2.89 and the left is 0.52. This would give us a lateralization ratio of 5.6 to the right and contralateral suppression of the left. Sorry, I think I typed the bottom wrongly, but this lateralizes to the right side. Now, 𝗲𝗏𝗵𝗏 PET-CT, that's where the CT nodule is on the CT scan. Right, you can see here is we give patients dexamethasone to suppress cortisol. And what lights up is then the CYP11B2 activity or aldosterone activity. The right is a lot brighter than the left. In the yellow arrow, it shows normal physiological uptake in the stomach. So we have a ratio of the right over left 1.75, which is more than 1.25. Now for this same patient, if I may share, then now we can measure hybrid hormones, which is 18-oxocortisol. So this is what we found in our cohort, and where the patient's level will be where the blue arrow is. So this patient has way higher levels than patients with bilateral PA, essential hypertension, and even the other non-KCNJ5 tumors, which are often smaller. So if we were to use this, then in the future, we could actually offer the patient surgery straight away once we have the aldosterone AR done, as well as the hybrid hormones performed. So treating PA in the future, right now we are dependent on baseline levels and the AVS. This patient was completely cured of hypertension. In the future, we may have PET-CT more widely available around the world. And certainly hybrid hormones, I think, will be one of the easiest tests. I understand in Myanmar, you send your labs overseas. So if you were to send it in the future to Singapore, we could potentially run hybrid hormones as well, and patients can be offered surgery from those results. So RFA will be an alternative to surgery, and aldosterone synthase inhibitors may be alternatives to our well-tried and tested spironolactone. So certainly treating PA in the future, I think, will be even more satisfying moving forward. I'd like to thank many people who have been part of our ASEAN network for adrenal hypertension. I'd like to advertise, and I know the Myanmarese contingent is usually very strong for AFES conferences. So we are having a joint conference with AFES. This is our first ANA conference over all 3 days, and we have a very esteemed panel of speakers: Bill Young, Paul Stewart, Gregory Klein, Guido from Europe and US. So do join us, and welcome to take any questions. I have also take many students and fellows from overseas, and we're always welcoming anybody who's keen to do attachment with us. And with that, I'd like to stop here. Thank you.
Thank you very much, Dr. Try, for your excellent presentation regarding primary aldosteronism, and also you're keeping your time limit within the time frame. And now, may I ask my co-chair, Professor 𝗧𝗺, to introduce the second topic and to proceed for the second section.
Thank you. In the second part of the adrenal symposium, the gear will be switched to another important adrenal disorders, 𝗑𝗺𝗵𝗄𝗧. So may I kindly request Professor Leilani to get on the stage. Actually, we don't need to introduce much, but I would like to add a bit about Professor Leilani and 𝗑𝗺𝗵𝗄𝗧. Professor Leilani has been collaborated and published research work on diagnosis and management of various aspects of 𝗑𝗺𝗵𝗄𝗧 and paraganglioma. Under her guidance, over 40 Filipino endocrinologists were involved in 𝗑𝗺𝗵𝗄𝗧 research with outstanding publications. And her academic research work has gone through over 100 scientific papers published in notable peer-reviewed journals. She is also a faculty member of ASEAN Network of Adrenal Hypertension, together with the first speaker, Dr. 𝗏𝗏. So without further much ado, may I request Professor Leilani to share your experience and exciting topic about precision medicine in 𝗑𝗺𝗵𝗄𝗧 and paraganglioma.
Thank you very much for the kind introduction. If you look at your International Diabetes and Endocrinology Conference, this is the endocrinology part of your annual conference, and I'm happy to see endocrinologists in the audience. I am tasked to talk about precision medicine in 𝗑𝗺𝗵𝗄𝗧, and this is a straight lecture. I enjoyed the talk of Dr. Troy, which is case-based, but this time it will be a straight lecture. So I will define precision medicine, talk about background and relevance of PPGLs, and talk about behavior and molecular clustering and approaches to individualized treatment. So at the end of this lecture, you will be able to understand that, characterize the behavior and hormonal and clinical behavior of PPGLs, and apply some algorithm in your clinical practice. Precision medicine is a term used now to describe medical care tailored to an individual patient in order to have a good outcome. Precision medicine is individualized healthcare with specific characteristics of a particular disease for a specific treatment. Today, physicians have the opportunity to exercise precision medicine approach to clinically manage and treat patients based on their genotype or the molecular phenotype. Earlier, I talked to our chairpersons. I said I might overshoot my time. Unlike Troy, he did a very good job, and I asked for the indulgence of the audience. So let me talk about PPGL's background and relevance. The chromaffin cells came from sympathoadrenal cell lineage with some signaling pathway and factors. They go to specific areas of the body. One is the paraganglia, coming from the base of the head down to the pelvic area, and the other group go to adrenal. So we have the extra-adrenal paraganglia chromaffin cells and the adrenal medulla. So a bit of the history of that brown chromaffin cells. In 1857, Dr. Werner, medulla of adrenal gland fixed in chromate salts, turned brown. He discovered it. Then Dr. Koh said, I have to call them, probably they have affinity for chromium, so I will call them chromaffin cells. In 1886, Dr. Frenkel first described pheochromaffin, and then Dr. Peake said, no, they are not affiliated to chromium, but these are chromaffin reaction due to oxidation of catecholamines. Now, a lot of the neuroendocrine tumors use chromogranin A as a marker for the neuroendocrine nature of a tumor. And then eventually we have the word chroma and color, and then pheochromocytoma. The characteristic biochemical secretions of this tumor will tell you if they are coming from adrenal gland. If they're coming from the adrenal gland because of the presence of the enzyme phenylethanolamine and methyltransferase, the norepinephrine is much transferred and changed into epinephrine, and then its metabolite is metanephrine in the blood. So if you get a lot of or increased metanephrines, there is already a clue that this is coming from the adrenal gland. Then the catecholomethyltransferase, both of the adrenal and the paraganglia, they have this enzyme, but if the biochemical characteristic of the problem is more of the normetanephrine increase, most likely this is paraganglia. Recently, they are talking about methoxythyramine, which is a byproduct of dopamine. The methoxythyramine is a marker if the paraganglia is cancerous and metastatic. Let's see some basic features of the PPGLs. The annual incidence is very, very low. It's 3 to 8 cases per million. They are heterogeneous. Some may be aggressive, some may be indolent. 30 to 35% of Caucasian patients show germline mutations, and the highest rate, these tumors, they have the highest rate of heritability. PPGLs are characterized based on their unique molecular landscape that allows their assignment to some clusters of heritability tumors. This may overwhelm you, but I just wanted to emphasize that there are, inside the mitochondria, there are certain substances and genes necessary for respiration of the cell, and outside is the cytosol, where you have the genetic mutation drivers. Let me give you an example. Succinyl dehydrogenase is important in the Krebs cycle. And then if there's mutation there, there is an increase in the reactive oxygen species. This will have an effect on some oncogenic suppression genes and will eventually wake up the hypoxia-induced factors. If this is increased in the blood, that will affect the nuclear transformation of some proteins, and there goes tumor formation. So eventually, generally, there should be two mutations, one coming from the mitochondria and the other coming from the cytosol oncogenic suppression genes. So if there are two mutations and there is hypoxia, there is disruption in DNA copy numbers, and therefore there is tumor growth and angiogenesis. Hypoxia is a very, very dangerous happening inside our body. Probably that's the reason why smokers, they are prone to have cancer because of the hypoxic environment in the cells. Remember that there are two kinds of respiration, the aerobic and the anaerobic. The normal cells thrive on aerobic respiration, so the byproduct is pyruvic. We call it posture effect, and the cancer cells, they thrive on hypoxic environment, and we call that Warburg effect. So in the body, we have hypoxia-inducible factors. These are factors that control energy, iron metabolism, erythropoiesis, and development. There are alpha and beta factors. It is the alpha subunit that are inducible by hypoxia. So in normal condition, the alpha should be degraded. But because of some mutation, the degradation might be affected. So in hypoxic condition, the alpha is stabilized. Once the alpha are stabilized, there is angiogenesis, glycolysis, apoptosis is decreased. There could be increased proliferation of cells and growth. And that's where tumor formation starts. So it's good to know that there are some related diseases, such as somatostatinomas, that can go along the 𝗣𝗵𝗺𝗵𝗵𝗺. Some they have polycythemia because of the germline mutation that results in increased erythropoietin and congenital polycythemia. So one of the recent about 10 years ago, report is 𝗂𝗫𝗃𝗃's and Dr. Zhuang's syndrome, where they found paraganglioma together with polycythemia in 2 patients because of failure of the HIF-alpha degradation. So again, if there's mutation and there's increased ROS, you can induce the HIF-dependent transduction pathways, and there goes the hypoxia signaling. This is very important because our carotid body in the neck is an oxygen sensing organ. It responds to hypoxia by increasing heart and ventilation rate. The CB paragangliomas, when they are there and they grow in the neck, have been recognized among high altitude dwellers and cyanotic heart disease, where there is a state of chronic hypoxia. I have once attended conferences of patients with paraganglioma, and some of the patients, they have a lot of knife cuts in their neck because of the increased recurrence of this paraganglioma. And one of them is a flight stewardess. She has to change her work because she couldn't be going to an altitude where oxygen is very low. So SDH mutations that disrupt the CB oxygen sensing will lead to inability to register normal oxygen levels. So chronic hypoxic stimulation of the CB oxygen sensing chip cells with the environmental hypoxia and SDH mutations can lead to the carotid body paraganglioma formation. And in that conference, there are a lot of patients that they have to change their residence from a very high altitude dwellers, and they have to change their place of residence to a lower area. So if there's a chronic hypoxic stimulation, which happens in increased altitude, there's increased severity of HDH mutated paraganglioma tumors. Let's talk about, so I'm talking about the clinical presentation. Let's talk about another way how we can characterize these tumors. One is the metabolomics, the collection, separation, and identification of the small molecule metabolites. So you have the tumor directly from the operation, then they bring it to a machine and they subject it to that machine where metabolites can be analyzed before pathology can be done on these tissues. There is development of capillary electrophoresis system and nano-HPLC system for rapid compound separation. A quick, inexpensive, quantitative, and relatively non-invasive way of monitoring human physiology, and it's ultra-high throughout clinical chemistry. So this is an example. The pink one is the sporadic pheochromocytoma, and the green one is the succinyl dehydrogenase tumor that is sporadic, that is syndromic and heritable. So here, you can see that the succinate based on the metabolome of the tumor is very, very high. If the succinate is very high, that will point out that the tumor came from a syndromic abnormality. So the succinate dehydrogenase problem, if there's increased succinate, there is a mutation in the cluster of succinate dehydrogenase cluster, mostly B, and this is very aggressive. If the mutation is in this area, it's very, very aggressive, very metastatic, and poor prognosis. So this is the clustering of the genetic syndromes. Succinate dehydrogenase is clustered. Most of them are autonomic dominant syndrome problems, VHL, NF1, RET, and TMEM and MAX. These are the genes of the different paraganglioma mutated genes. So what are the clues to a specific disease entity? One is biochemical. I've already pointed out to you the paraganglioma, they usually bring out normethanephrines, and the adrenal is the methanephrines. Another is imaging. Location of the tumor is one, and clinical behavior is another. So the most common is the head and neck paraganglioma, and the other places are the abdomen, renal cell carcinoma, and the gastrointestinal GISTs related syndromes. So the factors that determine the clinical presentation are: one, the anatomic location; two, the catecholamine secretion, the pattern, the amount, and the type; three, germline or somatic driver mutation, being benign or malignant, and the time elapsed from symptom to diagnosis. So let's look at the biochemical phenotyping. The specific hereditary pheochromocytoma metabolomic phenotypes by plasma O methyl metabolites are the following. If 99% of if it is normethanephrine and methanephrine's combined, maybe MEN2 and NF1, neurofibromatosis 1, multiple endocrine neoplasia 2. If there is methoxytyramine and NMN, usually VHL, and a very, very high, 78% of methoxytyramine may be SDH, probably B or D. How about clustering based on genetics and molecular pathways involved in the PPGL tumor regenesis? Don't be afraid of this. I just wanted to show you that clustering was possible and made based on their molecular behavior. So for cluster 1, so this is, there are several structures or transduction pathway that were affected by mutation, and that brings about the clustering of these tumors. So the cluster 1, they color-coded the different mutated oncogenic gene driver mutations here, and they are related to the Krebs cycle, noradrenergic in biochemical phenotype, very metastatic and very recurrent. So the cluster 1 would be implemented, and the most recently discovered is their relation to the IRP1 or iron regulatory protein 1, so that these patients may present with polycythemia. Cluster 2, on the other hand, these are the tumor mutation oncogene drivers. They are more related to kinase signaling pathway, more adrenergic in their secretion, and they are less aggressive. They include some abnormalities in the chromatin remodeling proteins, and their regulation will activate the pathway resulting to tumor formation. I just wanted, by saying that, I just wanted you to see how extensive the work has been done to characterize these tumors based on their molecular behavior and biochemical behavior. Later, I will tell you why it is important. Then cluster 3 is increase of target genes involved in Wnt receptor and hedgehog signaling pathway. This characteristic of this cluster 3 is not yet well defined. So, based on the guideline, what is it that we have to do for genetic testing? This has been reported by the group who is in the pheochromocytoma for the paraganglioma for the past three decades. All patients with PPGL should be engaged in shared decision, especially with their families. Use of clinical feature-driven diagnostic algorithm to establish the priorities, which among those genes, because it is very expensive. Remember that we don't have certain criteria just like SLE criteria, diabetes criteria. These are very, very rare tumors that they have to be on the clinical behavior side and biochemical behavior side of the tumors and not the ordinary clinical criteria. Patients with paraganglioma undergo testing of SDH mutations, and that patients with metastatic disease should undergo the HDAB mutations. Genetic testing must be delivered within the framework of healthcare, not only of research. It has to have a pre-test and post-test, and all tests should be done in an accredited laboratory. Okay, so let's look at this algorithm. The family is unknown, and then if the patient has no polycythemia in the family, so these are the biochemical tests that will point out if it is VHL or SDHP. So noradrenergic, these are the increased biochemical result. These are the different genes that can be tested. If it is adrenergic, these are the genes that should be tested. So if there is polycythemia and primarily noradrenergic secretion, these are the genes mutation that should be tested. How about imaging? Imaging should be personalized. Based on the tumor's biochemical and genetic profile, you have to choose because one, it's very expensive. Two, availability is a challenge. So, and of course, you have to think what part of the body should be tested and the size. Let's review where we grew up in the past. We grew up in the MIBG imaging of pheochromocytoma. This 𝗤𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏 the tracer attaches only on the cell wall of the tumor. So when the PET scan with certain tracer, and the tracer can enter the cell and the tumor, and the tracer can be metabolized by the tumor, the imaging improved to almost 100% specificity and sensitivity. So here is an example of a 39-year-old with SDHB-related metastatic PHIO, look at the MIBG result. The MIBG result did not show much, but when the advanced tracer were used, the 𝗤𝗏𝗚-FDG, you can see how much metastasis the patient has. So this is another example of an MIBG that did not show much in a patient with MEN2, and you can see by doing MDG, DOPA, FDA PET scan, you can see a very clear demonstration of metastatic tumors in the patient. So we go along to do functional imaging, and this is the algorithm. So if we are suspecting just a sporadic pheochromocytoma, we can do FDOPA PET, and if it is negative, you can just proceed and monitor it with MIBG. But if it is yes, if it is FDOPA is not available, MIBG, but if it is available, just do it. So next is hereditary PPGL. If yes, SDX mutation, it is positive genetically, then you go to the 𝗣𝗿𝗏𝗚 SSA. That's the first line. There are the second line. Again, this is a challenge for a lot of Asian countries to have this kind of PET scan advanced at that, and but just to know, and nice to know that this algorithm will help us, if not now, in the future. What is interesting recently is that the catching of these tumors and these patients with pheochromocytoma and paraganglioma is less and less of clinical symptoms. Most of them were diagnosed based on incidentaloma. Look from 1980 down to 2018, you can see increasing diagnosis based on incidentaloma findings and genetic surveillance. So here is a proposed personalized diagnostic algorithm for PPGL. If there is incidentaloma or clinical suspicion or with already genetic surveillance, again, you go to biochemical testing. So you do the anatomic imaging, CT and MRI, and the functional imaging. And then, so based on that, the patients, based on that, you have to study the tumor, either doing blood or saliva DNA and the tumor DNA, comparing that, and see if you are dealing with no mutation, somatic mutation, or hereditary mutation. So this is the simplest algorithm that the group have shown us. So based on molecular landscape, PPGLs were grouped into clusters. The clustering was essential to ascertain the following: clinical behavior and prognosis, guide individual diagnostic procedure like biochemical, interpretation, choice of the sensitive imaging modalities, and provide personalized management and follow-up. Okay, so if we go by cluster-specific therapy of inoperable metastatic disease, they said it's very difficult and seems to be not feasible. So therefore, the group experts went to the personalized genetic-driven treatment. So some published guidelines and expert views within each cluster led to the coherent individualized patient management plan. So any plan is individualized based on the previously mentioned characteristics. Let me give you an example how a consensus is made. So this consensus is on guideline on the management of pheochromocytoma and paraganglioma in patients with SDHD. SDHD usually is the head and neck. Oops, sorry. So the locations can be in the carotid bifurcation, a ganglion, jugular bulb, or middle ear. That is very important to localize. So the group of experts will assign a chairperson, and the working group is divided into steering and rating group. All members who participated in the development are experts in PPGL and represented various countries' practice setting a discipline, and one of that is endocrinology. So it is a multidisciplinary team with radiologists, nuclear medicine, geneticists, and pathologists. In August 2021, the steering committee was completed, and then we graded the framework. In February 2022, we start rounding voting or proposed recommendations. Just imagine the time in Europe is different from Asia, so you can be like 2 a.m. waking and discussing, you have to be awake by that time. June 22, September 9 meetings, again, members, rating, and steering groups. And then September 22, the group has final version of the consensus, and the paper was published in May 2023. So that is how precision medicine is made. So it is a consensus of experts all over the world. So this is the current synthesis of the important clinical facts that contribute to the decision making. Patient with SDH related head and neck paraganglioma, we get the precision medical card, patient condition, localization stage, using MRA, CT scan, PET scan, cranial nerve functions, clinical, audiogram, laryngoscopy, biochemical spectrum, metanephrines, plasma methoxytyramine, and patient preference. So it is a multidisciplinary tumor board. We decided management one, based on the finding. Do we have to just wait and watch? Do surgery or therapeutic radiation is necessary at that stage? Management two, we have to localize based on the treatments, targeted radionuclide therapy, TKIs, and some important biochemical and chemical drugs that should be used. So once we have decided on how the patient will be managed, then we follow them up. Stable disease or slow disease course, and they are divided into stable disease, those with moderate disease and moderate high tumor burden, and rapid disease with high visceral tumor burden. And then we consider further treatment. If we see if they are progressing, we put TKIs and chemotherapy. With rapid progression and high tumor burden, we go chemotherapy and probably put them into trials as they still are alive every year, year in and year out, and do some TKIs treatment. So how do we follow them up? So for children and adults, we do HNP every 12 to 24 months to 36 months. So HDAC, 10 to 15 years, they live as long as they are followed up and treated well, they can live up to 15 years. For adults, history and PE, basic metabolic panel, and imaging. So look here that the follow-up is 12 to 36 months. So for low risk, intermediate risk, and high risk, the imaging is done every 5 years, every 24 to 36 years, and every 12 to 24 months. So the brief summary for that, before I close and give you my insight, is determinants of prognosis is genetic predilection, tumor load, biochemical phenotype, disease progression, and presence of metastasis. Better survival are those with head and neck paraganglioma, metanephrines less than 5-fold the upper limits of normal, and low proliferative index. Poor survival were reported on male sex, older age at time of diagnosis, larger primary tumor size, high dominant levels, incomplete resection, and presence of distant metastasis. And of course, the treatment is a combination of radioactive and chemotherapy. With stage tumor targeted treatment modalities now, some affected individuals have lived with metastatic disease for more than 20 years, and that's a good news. So this is my summary and insights. Pheochromocytoma and paraganglioma are rare tumors and yet with high inheritability. There is vast heterogeneity in the clinical presentation that led to clustering of syndromes. Clustering of syndromes was based on unique PPGL features on their biochemical, phenotype, imaging, and genotype. These unique PPGL characteristics paved the way to tailored diagnostic management and monitoring schemes we call precision medicine. So the conclusion is, with precision medicine in PPGLs, we can have a personalized path to optimal care. I just wanted to flex Dr. 𝗂𝗏𝗄𝗃, whom I was able to collaborate training with my fellows. After Philippines, they go there for 6 months, and he trained them on paraganglioma. And I have helped 40 endocrinologists Filipino to go there at the NIH from 2008 and 2018. They're now all over the country serving our people. Thank you very much.
Thank you, Professor Leilani, for your very comprehensive and informative talk regarding the personalized path to optimal care of pheochromocytoma PPGL. Now we're going to start Q&A sections, and now the floor is open for Q&A section. Any comment, any discussion, any questions?
So I've seen in a lot of your slides that we know that PA decreases renin, and that the renin-angiotensin system will be sleeping. But I see some still that you're using valsartan and ACE in controlling their blood pressure. So I don't know if they have an effect. That's one. Number two is, in the preparation of workup of these patients, you said in your steps that you have to withdraw spironolactone for 6 weeks. So what I understand, and probably in my experience, is not unless you are entertaining cyclical aldosterone, the renin-angiotensin system should be sleeping all the way even if you take out the spironolactone. Because in a lot of my patients, the renin-angiotensin system will just wake up 6 months to 9 months after the adrenalectomy. So the point that I'm trying to drive here is I do not withdraw spironolactone. It's very difficult to withdraw, especially for 6 months, because their potassium dives, and the blood pressure goes up without the MRA blockade. So those are the two issues that I wanted you to comment on. Thank you, Troy.
Thank you, Lani, for the question. So I guess the first one was about the use of ACE and ARBs, and not just them. I think there's also beta blockers and diuretics that can alter your aldosterone and renin levels. On top of that, hypokalemia can also suppress aldosterone levels, and a lot of our patients have quite severe hypokalemia. They may need a lot of potassium supplementation. For us, we use potassium tablets with 600 milligrams, which is about 8 millimoles of potassium, and some patients may need 10 to 20 tablets. So I think the most recent EndoSOC guidelines do appreciate that it's difficult to stop all the medications, and they do appreciate that it's hard to correct the hypokalemia. And I think they've gone one step further. So they've said that if you are on an ACE and you're hypokalemic, all these actually lower your aldosterone levels. Despite lowering your aldosterone levels, if your test is still positive, then this is a positive test, and you can go ahead with your next steps. You could skip confirmatory testing, you could skip your salt loading test and go straight for subtyping, as you may call it, right? So I think they have gone one step further, and I think a lot of people in the field agree with them. It is ideal to have to stop less medications, the better, because it is, like you said, very difficult to stop medications. I'm not sure if you're also asking whether ACE will be effective for patients with PA, because it does block the aldosterone pathway, but it does block upstream. So generally, I find that ACE inhibitors and ARBs are not very effective for controlling blood pressure for patients with PA. Then your second question is about spironolactone. I agree that spironolactone is very effective for patients with PA, and if we stop it, they may potentially, have very severe PA phenotype with severe hypertension, hypokalemia. So far, I have managed to get by stopping spironolactone altogether. So, like I said, some of my patients may need up to 20 tablets of SpanK. So generally, I still try my best to stop spironolactone. They do stipulate that 6 to 8 weeks. So generally, I would stop 6 to 8 weeks. I don't go to 6 months. But the whole process of doing AVS can straddle up to 6 months. And there are data to show that you can perform AVS, you can perform functional imaging on spironolactone. I think it is fair if you do need to give spironolactone, as long as your patient is still hypokalemic, despite spironolactone, then they are still manifesting with endocrine hypertension. In which case, then, measuring your aldosterone and your renin levels will still be accurately reflecting the state in the patient, and you could still diagnose them. Yeah.
Thank you, Troy.
Is there any questions from the audience about primary hyperaldosteronism as well as paragangliom? Thank you, Professor Tan-Tan-Yi.
Thank you, Troy, for your very informative talk. And also I'd like to thank Professor Leilani for highlighting the precision medicine regarding the paraganglioma. Although these are the very new for us in a low resource setting. So the questions or experience I would like to share or ask to Dr. Troy is that in case of primary aldosteronism, I got a Conn syndrome with in an elderly man. He has been undiagnosed for many years probably. So when he was diagnosed, there's we find an adenoma and all the typical features of Conn syndrome, but we didn't do the adrenal vein sampling, which is not available. So I referred the patient to the surgeon, and then the adrenalectomy was done. But after post-op a few months, the patient got hyperkalemia again, low blood pressure, and the creatinine levels go very high up. So he finally ends up with a renal replacement, HT, hemodialysis. So is it the complication of the Conn syndrome after operation? If undiagnosed for many years, so the patient has hyperkalemia, low blood pressure, and creatinine, renal functions deteriorated very quickly in the post-op.
Thank you.
Do you have any case report or something like that?
Was the creatinine and was the baseline kidney function normal?
Baseline? Kidney function, slightly, not very good actually. CKD stage 3, something like that.
Okay, so I have had similar cases, and same thing, CKD stage early 3, I think 3A. So because we do perform AVS with contrast, so we are a bit more cautious about sending patients for AVS if they have renal impairment. It is well known that patients with PA have higher chronic kidney disease risk, so they will have proteinuria and they can have a low GFR, just like diabetic nephropathy. And it's also well known that after we treat them medically or surgically, it will worsen. So the worsening is in the acute part, and it stabilizes after that. So to reassure our patients, sometimes we can measure the protein. So you would see the protein coming down or your albumin coming down, just like when we treat our patients with diabetes with ACE. If we do not send them for AVS, then the question is, at what level do we feel confident, because we know that the creatinine is going to shoot up. So generally by stage 4, I wouldn't push it too much. If your patient's already 3B, like GFR about 30-ish, I would be worried that they might go into end-stage renal failure after surgery. So in these patients, one way we could get around it is to challenge them with a spironolactone first and see how bad it goes. And if you see that their GFR is going to approach 10 or 15, then you may decide not to do the adrenalectomy. The patients can also develop pseudo or temporary hypoaldosteronism because of chronic suppression on the other side. So hyperkalemia has been seen, relative hypotension. So sometimes you may want to give fludrocortisone to bite them through for a short period of time until the other adrenal gland improves. But again, if your patient already is close to approaching end-stage renal failure, then I'll be a bit more cautious about sending for surgery.
Thank you. I'm just wondering, I was wrong to refer the patient at this stage, whether we should treat as a conservative only with the aldosterone, spironolactone, you see, is doing well.
Well, I mean, on retrospect, it's easier to say. Sometimes we really do not know how they will do. Actually, I sent a few patients that for surgery, and their GFR dropped down to, I think, 25. So I was a bit worried as well. But eventually, it stayed there and it plateaued at 25. But I guess moving forward, yes, it might be safer to challenge them with the medical treatment first. And then if they seem okay, then send them for surgery. Yeah.
Thank you. Thank you.
Yes. Thank you, Professor Try and Professor Leilani, for your comprehensive lecture. I have one question from Professor Try and Madam Leilani. First, I would like to ask Professor Try. I follow your EMS's Mayo Course adrenal lectures. I'm very interested in that. And my question is, I've come across one PA patient. He has adrenal adenoma with a raised AR ratio. So we do the adrenalectomy, and biopsy confirmed adrenal adenoma. And then after that, his hypertension, control, and normal kalemia. So we stop antihypertensive drug, and the patient, we think that he is cured. But after 2 months, he got hypertension again, and he came and consult with me. But serum potassium found to be normal. But we can't do the post-off AR ratio because we cannot send sample in these days for some reason. That's why I have to give the spironolactone and antihypertensive, but it's okay. So what's your opinion for that patient? Is it due to the hyperplasia at the adrenal other side, or what should we follow and monitor for him? This is my first question. Thank you.
I think it's very hard to tell without ARR. He could also have hypertension from other reasons because hypertension is very common, affects 1/3 of people. So if your ARR is done as normal, then hypertension may persist, and actually 2/3 of patients around the world to 3/4 may have hypertension persisting after adrenalectomy, even though they are cured of PA. Yeah.
Thank you. And for Madam Leilani, and in these days, the junior internists and dermatologists, they are very great, enthusiastic in the finding the physical signs. So they show need for the endocrine referrer for the 𝗂𝗏𝗿𝗏 spot or the nail fibroma or Sjögren patches, etc. And with the criteria, they diagnose as the von Hippel-Lindau or tuberous sclerosis. But they showed to endocrinologists for the effluxion or endocrine diseases. But in these patients, they are totally normal, their blood pressure is normal, serum calcium normal. So I noticed your word, 𝗍𝗿𝗶𝗺𝗵𝗲. So what's your opinion for rare genetic syndrome? So how should we monitor frequently, or do we do the genetic testing for that? Because they have no family history at all, like the similar clinical problem. Okay. Thank you very much.
Thank you for the interesting case. It is the same case as what you have asked, Dr. Troy, right? Okay, so let me just, is it the same case? It's a different case. The first question is, how do we screen? How do we screen a patient with pheochromocytoma, right? So it's very difficult, actually, even in our countries, if we suspect the positivity of 24-hour urine metanephrine is very, very low. And then even if we have a positive and then we do CT or anatomical scanning, there should be a 3 times increase from the normal range, isn't it? That's the guideline. It's very difficult to get that. But even if we get that, sometimes the anatomic is negative. Now, we have to control the blood pressure very much. So use your alpha blocker, and then eventually with a beta blocker and calcium antagonist. We have to be very, very patient in working up the patient. It's very expensive to have the PET scan, but you can go there. As long as you control the blood pressure, take time to look for the tumor. You cannot just do genetic, not unless you have a positive biochemical and supporting imaging result. We cannot. So just be patient. I don't know how to answer that, but we encounter the same challenges in the Philippines.
If I may want to ask one question for Prof. Lani. I just want to ask about genetic screening. So it is recommended that it's very common and we should, do genetic screening in more patients. But do you have any challenges in trying to offer screening for the younger patients? And how do you manage to convince them to proceed with genetic screening?
Say that again, Troy.
Do you have difficulty offering a patient genetic screening? Because it's very common that they have genetic mutations, but the young patients especially, even though it's still recommended, or even sometimes the older patients, they are not keen on doing genetic screening.
Right.
Yeah.
Right.
How do you get around to convincing your patients?
How do we get the genetic test done? Is that the
Yeah,
question?
how do you convince the
So
patients?
in the Philippines, we have MEN2. We have a National Institute of Health in the government hospital where we can send it there. Second is we do collaborative with some other countries. One is in China, with Dr. 𝗂𝗏𝗺𝗃𝗧 sometimes, but it's difficult in sending the samples transatlantic. That's why I think we have to have a close collaboration among Asian countries where sending specimens need a shorter time, and the preparation to care for the sample will be easier because of a shorter time of transit. So we have small genetic mutation tests, but not all listed in the guideline.
As the time is running short, may I allow Professor 𝗏𝗺𝗻𝗿 to give you a comment on questions, and after that we are going to conclude this section.
Thank you. Thank you both speakers for your excellent talk. I want to have your opinion from Professor Leilani. Because of the use of medical screening being very common in this country nowadays because of the marketing, a lot of MRI and the abdomen scans have been done to many patients necessarily or unnecessarily that lead to the diagnosis of incidental tumor without any symptoms. However, as an endocrinologist, I've been seeing pheochromocytoma, particularly pheochromocytoma, almost every year. I mean, you say 3 to 5 patients for me every year. And my experience, we cannot practice the precision medicine because we have a very low, limited resources. So eventually we resort to surgery for the pheochromocytoma. And my experience is, as you just mentioned, alpha blockers. Control of blood pressure is very important. Alpha blocker and then beta blockers. And it is very important in post-operative period to maintain the blood volume. My experience is over the last year, 5 patients subjected to adrenaline. I think 2 patients left with post-operative period stroke because of the volume contraction. So what's your advice and what's your opinion? So how to manage the patient blood pressure and the volume maintenance so as to prevent volume contraction after the post-operative period that can lead to reduced blood supply to the brain, leading to the stroke.
Yes.
This is the practical problem. The problem is the collaboration between the anesthetic and us. Anesthetic, they don't usually follow our advice. They just do it. And the surgeon also, they just want to do it. And then 2 patients or 3 patients left with stroke after post-op period. Hypertension is controlled, but left with stroke. So what's your opinion?
Okay. So first I wanted to comment to the patient of our gentleman, Dr. Gentleman, who said that there is adrenalectomy, but there is recurrence of the hypertension. I've seen pheochromocytoma with secondary hyperaldosteronism because of the vasoconstriction at the renin-angiotensin juxtaglomerular cells. So I've seen a potassium of 2.9, but the patient is pheochromocytoma. So it's very difficult not to have sampling, really, in PA. It's not anymore at this time, the evolution of adrenal hypertension is not anymore blood pressure. They are dead because of coronary arrhythmia and congestive heart failure because the circulating excess catecholamines and circulating aldosterone destroys the heart. There's inflammation, fibrosis. That's why the advantage of doing sampling, if this is bilateral, is to take one just to unload the system of circulating hormones so that the blockade with spironolactone may be easier than have 2 very active adrenal glands. So for PA, I think Dr. Troy has shown how he controls the blood pressure very excellently. And with the spironolactone, MRAs, whatever you have in your country, and the calcium antagonist. And then for pheochromocytoma, you have to combine also with calcium antagonists, alpha blockers, and beta blockers. The blood volume, because of the circulating, the blood volume, you cannot do anything about it. You are not giving spironolactone because of the diuresis. You are giving spironolactone to block the aldosterone at the level of the kidney. So we cannot do anything on the volume at all, except if you block it, of course, you control the increased blood volume because of the aldosteronoma. Yeah.
Okay, thank you very much. Before giving the conclusion remarks by the Professor 𝗵𝗿𝗏, as a general physician with my experience, I like to give a few comments upon this section. The first one is, Dr. Troy, thank you very much, highlighting the high prevalence of primary hyperaldosteronism. According to the traditional thought, we know that hypertension, when you think about the hypertension, primary is at 95%, 5% is a secondary. Out of secondary, there's many causes like renal, endocrine, drugs, obesity, etc. But Dr. Troy highlighted the 5 to 20%, but according to the literature, some say to 5 to 15% of hypertension cases are primary hyperaldosteronism. We should not underestimate the prevalence of the primary hyperaldosteronism, and whenever we find a person with hypertension and hypokalemia, we should investigate further, like ARR, aldosterone renin ratio, if possible, and if there is more facilities and feasibility, we can do the venous sampling and identification of the tumor site by the advanced imaging, because secondary hypertensions are actually curable. Although the primary hypertension is not curable, secondaries are curable. That point is very important for us. He also highlighted the importance of the imaging procedures, and then some of the biochemical tests to confirm the primary hyperaldosteronism. But for the second speaker's talk, as a clinician, I remember when I attempted my MRCP exam, we have to remember the pheochromocytoma in 5 P's: paroxysmal panic, perspiration, palpitation, and pheochromocytomas. Those are the things in clinically. But Professor Leilani pointed out that personalized path to approach and the management, which is really, really costly. We need to do the genetic studies, and we have to do the more advanced imaging, but also which is really beneficial in the patient's management. In the future, we have to consider the individualized approach to manage an individual person as a personalized approach. Now may I hand over the microphone to conclude this section by the Professor 𝗏𝗏.
Thank you. Before conclusion, I would like to say a few words that adrenal symposium has driven our adrenaline rising and raising a lot of questions. Actually, we want to ask so many questions, but both lectures gives bunches of vital information, how to diagnose and management of very common adrenal disorder, which we encounter in real life, day-to-day practice of management of hypertension. And as Professor Aung said, TRI has touched that updated test for the PA, because AVS, we are not accessible to AVS, but PET scan or that oxocortisol, maybe we can have her in the near future. For the Professor Leilani, actually we do commonly see pheochromocytoma in our practice, but honestly, I haven't come across about that PPGL in my practice. Maybe we have not paid attention to those kind of cases because we don't have that STH mutation testing and things like that. But I've learned a lot from you about that hypoxia-inducing factor and that STH mutation, which are very important to look for the PPGL and metabolomics and things like that. So thank you very much, both of you, for giving us the very insightful and illuminating lectures about the adrenal hypertension, and especially Professor Leilani for coming to us. And also, I would like to send thank you notes to Dr. Troy for joining us from Singapore. I believe because of both of you and ASEAN network of adrenal hypertension will be growing with great prestige and success. Thank you for all the audience to wait to this last part of this symposium. So shall we show our appreciation to both speakers by usual way?
Thank you.
Thank you, Troy.